I will talk about the HemaClear Model A for foot and ankle surgeries. My name is Mauricio Povoa Barbosa. I am a member of AAOS and AOFAS and hip and knee surgery, the college, the American College of Hip and Knee Surgery. I did my fellowship at Northwestern University in Chicago. This is my disclosure. And all these surgeries that I will show was done in HCor, the hospital. I work in 2 hospitals here in Brazil, HCor and Albert Einstein. But this study we did in HCor. And I'm a member of the Hospital Infection Control Committee since 2014. I'm the only surgeon in this committee. So we will talk a lot about infection here today. So this is a patient that did a surgery 8 weeks before this picture, and it was a first metatarsal phalangeal joint fusion. And he came to me with this kind of problem, and he was taking antibiotics, but he didn't went to any other surgery to wash up or to clean. And when I received this patient, I need to do another surgery to clean, to remove all the hardware, and he used vacuum to treat the infection, and he received a lot of antibiotics. He stayed at the hospital 3 weeks after the second surgery that I did. And this is the most important topic that I will talk to you today, because the amount of money and all the suffering that this kind of patient suffer after an infection is what we need to think about and what we need to avoid. This is another case of infection after Achilles repair. This patient was treating this kind of infection for 4 months, only with oral antibiotics and ointment. This is, for me, this is unbelievable, but he didn't go to another surgery to clean or to remove the suture wires, or he didn't. He was just being treating ambulatory and not surgery. So when I received this patient, I did an aggressive surgery. I removed the Achilles tendon. I removed all the suture anchors that he had in the calcaneus, and he stayed 1 month in the hospital to treat the infection. And then I did the Achilles reconstruction with hamstring tendons 6 weeks later after this surgery. So this is, again, amount of suffering, amount of money with this kind of problem. So this is one picture of HemaClear when I started doing my surgeries. This is an old picture from 2010, and the surgery was fasciotomy. At that time, we didn't have the HemaClear Model A, so we use a regular HemaClear according to the circumference of the spot that I would use the HemaClear. This is another picture of surgery that I was doing. This is a elbow fracture, HemaClear in the upper limb is, for me, it's amazing because the field that we have to extend the incision proximally is what is, for me, the best quality of this kind of tourniquet. Because when we are using the pneumatic tourniquet in the upper limb, we lose space because of the tourniquet. Here is another surgery, quadriceps rupture. And the idea to use the HemaClear here is not only the other qualities of the tourniquet, that is sterile and avoid DVD, but it's not to stuck the quadriceps. As we put in the upper thigh, we can do the surgery without problems with the quadriceps. When we use the tourniquet, regular tourniquet pneumatic, it's not uncommon that we need to release the tourniquet before fixing the quadriceps because the quadriceps is stuck. This is another surgery that I was doing. It's a total knee replacement, and I always try to use HemaClear in my surgeries to avoid infection and to have more field in my surgery. And this is another situation that we cannot use the HemaClear model A, because when we have Achilles tendon rupture or Achilles tendon avulsion in this case, if we use the HemaClear model A, the HemaClear can stuck the cuff, and it's not easy to pull down the Achilles tendon. So in this kind of situation, I prefer to use a regular HemaClear in the upper thigh. So this is how we use the HemaClear model A. This is a video, and it's very quickly video without sound. The HemaClear model A, we use below cuff, and I can use for most of the foot and ankle surgeries, even fractures of the ankle, and I will show you in the presentation. I do not do Achilles repair or Achilles avulsion with the HemaClear model A. When in this situation, I use a regular one. So this is some cases using the HemaClear model A. A ligament repair we can use without problems. Talonavicular fusion. The HemaClear is below cuff. Peroneus brevis tendon repair. I like to use the IOBAN over the skin. In most of my cases, I use it. Osteochondral defect. This is a simple case of osteochondral defect. And this is a huge lesion. This patient suffered a huge lesion of the cartilage of the talus, and we use a cartilage graft here. It's not allograft, but it's from animal. It calls CARES It's like a gel of cartilage. And here is another case that I used the HemaClear model A, but this case I should not use because this patient had a huge calf. It was almost impossible to leave the HemaClear in the correct position. The correct position was where I have this line here. I used to draw a line where I want to leave the HemaClear, but the HemaClear could not stay there because the cough was huge. So I could do my surgery, but the tourniquet was very close to the incision. So in 2019, we started a study comparing the HemaClear Model A versus pneumatic tourniquet in the upper thigh. So the HemaClear Model A, I use below calf, and the pneumatic tourniquet I use in the upper thigh, as we use regularly in the most of our surgeries. This was a official study from Brazil, and we started in the end of 2019. We had some problems because of the pandemic, so we need to wait until the cases return. So it took some time to take all the patients that we need. So all the surgeries was done in HCor. It was 65 patients, 4 bilateral, so 69 feet or ankles, and 3 months of follow-up. There were 33 HemaClear and 36 pneumatic tourniquets. One surgeon, it was me, and the same team. 34 left and 35 right, 44 females, 25 male. The range was from 18 to 75 years old. All patients received aspirin, 200 milligrams per day per 30 days. And all patients received prophylactic antibiotic for a maximum 24 hours. It was 26 ankle fractures, 11 foot fractures, 6 ligament repair or reconstruction, 1 total ankle replacement, and 25 other elective cases. The ischemia time varied from 8 to 140 minutes, average time of 66 minutes. The reperfusion time was less than 10 seconds. Most of the cases was 4 or 5 seconds. No DVT in any patient. No clinical problems after releasing the tourniquet. No pain due to the tourniquet. Doesn't matter if it was HemaClear or pneumatic tourniquet. We had 6 cases of superficial infection in the pneumatic group and 0 cases of infection in the HemaClear group. The infection group was 4 cases of ankle fracture, 1 case of Lisfranc fracture, 1 subtalar fusion, and 1 tumor recession. So it was 5 emergency and 2 elective cases. This was one patient, one example of infection or a subtle infection, because all the cases I saw in 1 week. So this was how I classified as an infection. This patient had a lot of pain that it was not correlated to the size of the surgery, even though it was a fracture, but the amount of pain was absurd. She had fever 2 days, and so I decided that this was a beginning of an infection or a subtle infection, and most of the cases are like this, as they were they were seen in 1 week only. And so I decided to give this patient, sorry, I decided to give this patient antibiotic and started a vacuum therapy. And 2 weeks after the vacuum therapy and oral antibiotic, it was much better than when we started. The ischemia time is an important part of the study. In the infection group, the ischemia time varied from 61 to 140 minutes, with an average of 89 minutes. And the ischemia time in the non-infection group varied from 8 to 122 minutes, an average of 64. So this is an important part of the study that we need to think about. We need to avoid this long time of tourniquet. Doesn't matter if it's HemaClear or pneumatic tourniquet. All the time that the patient is under ischemia, the antibiotics are not in the field. So the patient is not receiving antibiotics at that time of ischemia. So we need to, as fast as we can, release the tourniquet. And we need to think about this all the time. All the cases of superficial infection were treated with oral antibiotics for less than 14 days and wound care only. No case required hospitalization, surgery to clean or to remove hardware. Our conclusions of the study is not published yet, but it was that HemaClear Model A is a very good option for foot and ankle surgeries, except Achilles tendon rupture, easy and faster application, no pain related to the tourniquet, and HemaClear Model A has not demonstrated any problem related to pain, DVT, or infection. Aspirin 200 milligrams per day per 30 days, it's absolutely safe for foot and ankle surgeries. The time of ischemia is directly related to infection. The volume of tissue under ischemia can be a problem. And should we start using only sterile products even when they are far away from the field? Because the pneumatic tourniquet is far away from our field. But even though it demonstrates that can be a problem. Thank you.
Wonderful. It's wonderful. It's really a pleasure to hear you.
Thank you.
I have a question. I'm sorry that I'm jumping the first one, but I really have a question. So the longer ischemia time, or let me ask you differently. How much of total ischemia time is wasted or spent on cauterization, on hemostasis?
Nothing, because I do my hemostasis after releasing the tourniquet.
With the pneumatic tourniquet also?
Both.
With both?
Both. Yes. I do my cauterization after releasing the tourniquet. I release all my tourniquet, all the tourniquet. I release the tourniquet in all my surgeries, always, and I do the hemostasis after.
I see. So it's not an issue of a longer surgery or longer ischemia time because of more time on hemostasis.
No, it was not.
Okay.
The longer surgery was because of the complex of the surgery. It was trimalleolar fracture or fusion. So it was longer surgeries, and this is why the time of the ischemia was longer, not because of the hemostasis.
I see. Okay.
And all patients receive antibiotics before the tourniquet. So they receive antibiotics usually 15 or 30 minutes before putting the tourniquet.
Okay. One more question, and then everyone will ask question. When you use the pneumatic tourniquet, how did you exsanguinate the leg before inflating the tourniquet?
Using a SMART
Okay.
band.
Good, very good. Okay, so we have something like 26 people on the call now. That's what I counted, but we have enough time so everyone can ask questions. Please unmute your microphone before you ask your question. Oh, 32. Sharon is correcting me. Okay, so please, questions.
Hello. Hey, Mr. Noah. How are you?
Hello.
This is Eduardo from Costa Rica. Thank you very much, doctor, for your presentation. I have a couple of questions. Do you say the infection is related with the ischemia? My question is related more with the time of the ischemia or with the percentage of the ischemia? Because with HemaClear, we have 90-95% of exsanguination. With the pneumatic tourniquet, we can take 50% of the exsanguination. What is the most important in order to prevent the infection in the surgeries? This is the first one.
I believe that it's the time because during the surgery with ischemia, the antibiotic will not be in the field. The antibiotic, even if we did the antibiotic before the tourniquet, the blood is not washing the field all the time and bringing antibiotic during the surgery. So in my mind, the time of ischemia is absolutely important, and we need to think about this all the time. More in my mind, but more than the level of exsanguination.
Okay, nice. Thank you very much. This is very important for us. The second question, doctor, is some surgeons say that they don't use ischemia for the knee replacement because the ischemia or tourniquets can change the angle of the prosthesis. If you put some pressure in the angle and they need to make some additions, how we can handle this kind of objection in the operation room?
So I try to use HemaClear in most of my knee replacement surgeries because of we fix the quadriceps very high with the HemaClear, and when I do surgeries in small patients or small and fat patients, and I don't have HemaClear because some hospitals in Sao Paolo, I don't have HemaClear. I prefer not using Tourniquet. So in this kind of situation, I do my surgery without Tourniquet because to not compromise the field of the surgery. So this is a situation that I prefer. But I don't have problems to put the implant, but I release the tourniquet before closing and to do the hemostasis. So I always release the tourniquet after cementation. I put the cement, I put the insert, and then I release the tourniquet if it's a pneumatic, or I cut the HemaClear and I do the hemostasis as long as it takes, and then I close. Probably it's better to close without tourniquet too.
Okay,
and
thank you.
You will not be in doubt that you can have a bleeding after the surgery.
Okay, this is my couple of questions. Thank you very much, Dr. Mauricio.
Okay, thank you very much.
Thank you.
Yeah, the question of flexion of the knee when the pneumatic tourniquet is in the middle of the quadriceps is very important in knee replacement and in knee arthroscopy, because when you splint the quadriceps in the middle of it, when you bend the knee, you stretch half of the quadriceps on a full range of motion. And if the surgeon is big and strong, you can easily stretch fibers or even tears of fibers.
Yeah,
so it's an important
the idea
question.
is to flex the knee. When we use a tourniquet, a pneumatic tourniquet, we should flex the knee before inflating the pneumatic tourniquet. So we use the smart band, and before inflating the tourniquet, we need to flex the knee more than 100 degrees.
Good. That problem, of course, does not exist when you place the HemaClear all the way up to the groin.
No.
Okay, who is next, please?
I have a question.
Hi, Antonello.
Hi, Professor. Hi, Sharon. Hi, Dr. Barbosa. I have two questions. One is, I don't know if I missed something at the first minute, the first minutes of your webinar. I talk with some orthopedics about to use the Model A about the foot surgery, and they said, oh, but we use to do the local anesthesia. So we have a problem with the pain of a patient. So my question is, what kind of how to use a Model A with local anesthesia for the foot surgery?
So most of my cases that I use Model A, the patient was under sciatic block. So the sciatic nerve block and saphenous nerve block. So most of the cases, and not a spinal block. So just sciatic. One option is doing a nerve block and not only an ankle block. The ankle block, it will be hard to use the HemaClear model A.